Now I request our President, Dr. Rajendran sir, to start the program.
Thank you, Dr. Thuru, and most respected our scientific advisor and VP South Zone 2024, Dr. M. Singarvel sir, and IAP TNSC President 2024, Dr. Balashankar, President-elect Dr. Somasundaram, Vice President Dr. Gopal Subramaniam, and Secretary Dr. Narmada, Treasurer Dr. Rajkumar, and Academic Coordinator Dr. Thirumurugan. So more than that, and I welcome our Dr. Srinivasan, teachers of teacher, on behalf of IAP TNSA, welcome sir. And I welcome two important persons from Karnataka. Is Dr. Ravisangara Marapalli. He is a ID person. He is going to be organizing secretary of National Pediatric Infectious Disease Conference at Bangalore. And he is a president-elect of Karnataka IAP and former Chief Election Commissioner of IAP, Central IAP also. On behalf of IAP TNC, I welcome Dr. Ravi Sangra sir. And I welcome Dr. Sri Krishna. He is a Central EB member and he is a person, EB member for National Pediatric Infectious Disease South Zone EB member. He is a well-known and young teacher for that infectious disease. Both are well-versed persons for dealing that pediatric infectious disease. And today they are going to talk about the effective use of serological tests. And yes, you know that lot of tests we are writing all laboratories. We are having many tests. We have to select and we have to write appropriate time and appropriate tests they have to write. I think definitely they will throw light regarding serological test in case of pediatric infectious disease. On behalf of IAP TVC, I'll welcome and I'll welcome all the delegates as well as other resource persons. Thank you very much.
Thank you, sir. Now I request our scientific advisor, Dr. Singaral sir, to say a few words.
Thank you, Thiru. Good evening to all. The most dynamic, respected President, Professor Rajendran, our teacher of teachers, Dr. Srinivasan, Rajkumar, and our Vice President Gopal, our coordinator for this program, none other than Professor Aswath, and other participants all here. Today's program, being the 10th issue, is going on very well. Aswath is very particular in bringing people of
stuck ಆಗ್ತೈತೆ ಅವ್ರದ್ದೇ ಪ್ರಾಬ್ಲಮ್ ಅಂತ Singarvel sir, we think we've lost your signal.
Yeah. Good evening, Ravi Shankara.
Good evening, sir. Good evening.
Good evening. No, sir.
Good evening, sir. While we wait for Dr. Singaral sir, I just request our Vice President, Dr. Gopal Subramaniam sir, to say a few words.
Thank you, Thiru. Respected President Rajendran sir, Singarvel sir, my teacher Srinivasan sir, Rajkumar sir, and other dignitaries. It's a great evening today. We are going to hear from the experts about the serological test in infectious disease. I thank Ashwath for choosing this topic. It's a very important topic, and I thank Ashwath for doing so, taking all the pains and taking all.
So all I think it's that's a connectivity issue. Gopal,
I
you
thought
can
it was mine.
Yeah. So we can go for through. You can proceed through.
Thank you, sir. I think now I request our Dr. Gopal. Yeah, you're back.
Cool. Yeah. I wish the program a grand success. Thank you.
Thank you. Now I request our convener for the day today, Dr. Ashwath, to take over the proceedings for the day. Over to Doctor.
Good
I think
evening,
Dr.
one and
Dr.
all.
Sorry, just 1 second. Dr. Singaravelu sir has rejoined. Singaravelu sir?
Thank you, sir. Am I audible, sir? Am I audible?
Yes, sir. Yes, sir. Yes,
Yes,
sir.
sir. Yes.
Just sorry, I'm in travel. I'm happy that within a short notice, our Ravi Shankara sir, who is a former Chief Election Commissioner of IAP, and our Karnataka State President elect for this year, next year, who is going to be the State President of Karnataka. Very dynamic person, both in academics and administration, and a great friend for all of us. I have been with him and enjoyed his commitment, involvement in both academics as well as in IAP. Sir, thank you, sir, for accepting our invitation within a very short notice. That is more important. Second, our young budding, very active Central EB member, whatnot, Dr. Sri Krishna, is he and his wife Sinchana, but both are from Mangalore, doing a great work. They are the true inspirations of our Professor Santosh Shon sir. So Sri Krishna has been both in academics as well as in administration. In our now he is a national EB member. Today he has got lot of commitments. In spite of that, he has agreed to be our speaker today. Thank you, Sri Krishna. In
Thank you, sir.
spite of
Thank you,
your
sir.
commitments, I am really welcome, and I welcome our Professor Srinivasan sir through our academic coordinator and all those involved in this today's program. And here, sir, we will all our postgraduates will join only in YouTube. We give only the office bearers important. Only we send the link. So with this program will be very useful. Our Aswath, our convener, will take over the proceedings. Over to Aswath. Thank you, sir. Thank you.
Thank you, sir. Good evening, one and all. We are forever indebted to the dynamic leadership of Dr. K. Rajendran and his able academic affairs coordinator, Dr. Thiru, and forever indebted for Dr. Singaravelu's guidance and the encouragement given by Dr. Srinivasan, Professor Thangavelu, and Professor PRC, sir. And we are also happy that the IAP TNSC is solidly behind this 4P series, as it is called. We are trying to reach out to the pediatrician who is practicing in a resource limited setting so that the best of science can be reached to the most needed areas of pediatric care. So we have chosen topics which will be relevant for the season, and we are also choosing the content to make sure that the practicing pediatrician is benefited the most. So for that, we have today two very eminent speakers in the realm of infectious disease who bring together both wisdom and age. So we have an old seasoned campaigner, Dr. Ravi Shankara, who is also neck deep in his busy preparations for the National PIDA conference to be held at Bangalore, which promises to be an exciting event. He is a head of department and lead consultant at Spurs Super Specialty Hospital, Bangalore. And he will be accompanied by Dr. Sri Krishna from Bangalore, who has been, as you have already heard, been a very, very dynamic and very enthusiastic performer in the state pediatric scene. So both of them bring a lot of wisdom and age and experience, and we hopefully will have a very, very useful and interactive session over the next 1 hour. I will not take more time. I will invite Dr. Ravi Shankara to give his guest lecture for the first half an hour so that we can have a more detailed discussion on pressing topics in practical pediatric infectious disease over the next 1 hour. Dr. Ravi Shankara, sir, if you are ready, you can start your presentation. Thank you.
Thank you, Ashwath. Actually, your voice so metal, like, you can join any, just like Amitabh Bachchan, Akashvani, everything. Fantastic voice I got. Really great. And my pronouns to Srinivasan sir. He's a teacher of teacher, a professor of professor. His appetite to learn it is endless. It's the way he will be the first one to join any Zoom meeting where the academic activities are going on. Really hats off to you, sir. You are really a encouragement to the youngsters how we should be as a doctor and learning more and more every day and night. Thank you, Srinivasan sir. And
Yeah,
also the Singaravelu, he knows Karnataka better than me. So I am the Karnataka state president. He knows each and every event so easily. He told Sri Krishna and his wife Sinchana Bhatt and everything. Hats off to you, Singaravelu. You are so point in recognizing the things, everything so well and keeping the things. Probably, I mean, we require the people like you. And Thiru, my another good friend, we'll be meeting so often in the last 15 days online, everything. And Rajendran sir, so what we call as the Amitabh Bachchan of Tamil Nadu, so young looks and everything. So nice of you. Let me start my this talk. This talk we prepared for the few reasons. As the president-elect, we traveled since last 1 year all over the Karnataka, even the deepmost medical colleges, everything like that one. And I was the judges for many posters and presentation. It was very interesting to know that most of the medical colleges, especially government medical colleges, even using the viral test and other tests, which the Whale Felix test, all those things, which most of the time the IFA has clear-cut told it has abandoned the viral test. In fact, most of the time they tell viral test has been abandoned. We know where we have recognizing that one. In spite of that, many papers, posters, even telling that we diagnose typhoid test, typhoid by doing the viral test is 1 in 160, 1 in 80, doing and within a week, and Whale Felix like that one. So we're really surprised what exactly is happening. And even if you go to the district headquarters also, even the most of the consultants are also using those things. When I ask that also, it is blood culture is not so easily available. You're all Bangalore people are blessed with so many things, blah, 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 like that one. I mean, there's a practical thing. We had to accept it. There is nothing wrong in that one, whatever they're telling that one. But somewhere we had to immediately, completely abandoning it and made it an orphan. Somewhere we had to bring it back, something like Madhyama Pandava. So somewhere we had to get some position, somewhere we felt like that one. So that's the reason actually there's a workshop of 4 hours where mine is one part of that one, where we are supposed to do in the district headquarters and the medical colleges, where we can come somewhere in between. Though heartily, I mean, in my mind, we cannot accept some of the things. We had to be somewhere like that one. So that's the reason we prepared this slide. If any mistakes are there, Srinivasan, you please, sir, you're my teacher. Always, I remember you. You can correct me anytime, and others also can correct me here. No issues at all. So just like him, I am also ready to learn. Even then, I'm not telling I know everything. I know a little bit that I'm trying to tell that one. So coming to the serology here, we know all of us what exactly a serology is. This is nothing but an antibody test. So that is in the blood-based test, as the name tells serology. So it is a blood-based test. So where it detects the antibodies against the foreign pathogen, whether the virus particle or bacterial particle, and with that we can. So an enemy has entered into our body. Our body has recognized that one and produced some weapons against that one. So recognizing those weapons, we are telling, okay, this infection is there. So how far this is good? Whether it is an old enemy still circulating in our body, or is a masking, the enemy, something like that. Instead of dengue, it is something else is coming and masking as like that one. We don't know what exactly it tells. So it tells something was there in our body, somebody has entered our body and caused something. So that's what it is going to tell. That is the meaning here. So we recognize that weapons in 2 ways, IgM and an IgG. All of us know IgM, that is the one that appears and stays for a few days, few hours to few days to few weeks, depending upon the infection. So the IgM we tell it shows the recent infection. How recent it is, we don't know. That is the point number 1. We had to remember that one. It could be 2 weeks old. It could be 1 month old. We don't know. Or it could be just 2 days old. That is the reason. I mean, what that is the infection is running on. That's what the IgM tells. And the IgP, it is always there. If it is a second infection, already some IgG has been produced. So that will be reactivated. So we are utilizing this opportunity. So there is a previous infection. Now the infection has come. Naturally, the body will produce more IgG. So a rise in a antibody titer, we take it as an evidence of a recent infection. That is the way we take it, that on IgG. Otherwise, in the first infection, IgG will not be there, as in the dengue for primary infection. We get it about some weeks later, like that one. So this is the difference we are going to do that one. On this basis, IgM and IgG, our when we are playing our game. So, of course, that we test the IgM and IgG in two ways. So, of course, there are many ways. The commonly we are using is on the rapid point of care, where it is very easy to do it immediate within a few hours. The result will come to us. So, that is one most popular one. Or an enzyme linked ELISA test. There are different varieties are there in that one. So, commonly it is called as ELISA. That will be more specific like that. It takes time, maybe 1 day or 2 days like that one. So there are two ways we are going to identify those IgM and IgG. So coming to this one, what exactly is happening? So this is a very important chart where we had to be careful about that one. We know the antibodies are produced only when the enemy has entered the body. So whether the viruses or bacteria in the blood, so when it is there, so we will see only the pathogen. Okay, that is an antigen, we can recognize that one. So we cannot recognize the antibody there. Only when the body reacts to that antigen and started producing, these antibodies bind to the bug and the bug will start disappearing. So we will get the antibodies only few days later after the bug has entered, and the antigen will disappear from the body. We will not get the antigen or the pathogen in the blood, only we will get the antibodies. This is a very important point we have to keep it in our mind. So this is what here happened here. The infection has entered, viremia has come there, there's a graph. Then later then the IgM will start appearing, it goes, then disappear. Then IgG also comes, somewhere it is there some lag here. And when the secondary infection is there, it will get reactivated and we'll get the IgG antibody rise in the antibody titers of the IgG. So this is a very important. So first thing is the viremia or the bacteremia is there, they won't get any antibody positive serology. Only antigen positive serology can be present, like the typhoid test. Or only when the antibodies are produced, the pathogen will start disappearing. During that time, if you do RT-PCR, it may come negative. So only the antibodies will be present. So this is a very important thing. So depending on that IgM and the IgG, what we are going to do is that one, demonstration of the specific IgM antibody, that is one way, and significant increase in the level of the specific IgG, that is antibodies between two consecutive samples taken, that is 4 weeks later they tell that one, or 1 week later that one. So there is a rising, IgG are done, that is the previous infection. Now the present infection, IgG has to rise. So if you do it 1 week or 2 weeks later, there should be a 4-fold rise in the IgG. Why 4-fold? That is an statistical data. Okay, so we have found that one only when the recent infection is there, body can produce a 4-fold rising. This one, that way you can have one-fold, 2-fold. That could be due to other reason. So in the only an infection is there, probably is the most significant data. That is we are taking a 4-fold rise, and that is the only reason. Some people ask, why 4-fold? Why not 2-fold? Why not 3-fold? It is a significant data. That's all. Only a 4-fold rise is there. We can tell, okay, then the recent infection is there. That is the only reason. Okay. Then coming to the next slide. So the interpretation is simple. So no exposure of the infection, IgM and IgG will be negative. Acute infection, IgM can be positive, and also IgG can be positive if it is a secondary infection. If the acute infection IgM, fast infection IgM negative will be there, only IgG will be there. So this is the way we are going to interpret it, that one. So now the question is this enough to diagnose the infection? That's what I discussed you initially briefly. So we had to have another weapon in our arsenal of the test. So this is not sufficient. That's what I'm trying to tell. Serology may not be always a definitive evidence of infection most of the time, except in dengue, NS1. NS1 is positive, we always take it is a dengue only, nothing else in that one. So coming to the next test. So what are the limitations of the serological test which are commonly doing and commonly believing that one, and immediately jumping into the sea? Yes, we have got the fish, we'll try to catch it. No, there are some of the limitations are there. So what is the thing? There is a window period. That's what already I told. Time-dependent antibody level. There is often a lag period between exposure to the pathogen and the development of detectable antibodies. That takes about 1 week in a case of typhoid. Most of the bacterial infection, they take about 1 week. And in some of the viral infection, they may develop within 3 to 4 days. So there is a window period. So don't try to jump into the conclusion something is positive, it should be there. Just see what exactly is happening. And there is a cross-reactivity, no non-specific reaction. We know some of the organisms from the same genus can have a cross-reactivity. Dengue can have a cross-reactivity with other infections in the body. Recently, I heard to the Vipin Visista lecture. He was telling if there is an exposure, an infection to the influenza, the dengue may be positive or dengue may not come. That is a simple Nepal study. So that is one good thing he was telling. Recently, just listened to him. So there is a cross-reactivity will be there. And cannot differentiate between active and post-infection, IgM versus IgG. That is a very, very important thing. As I told, IgM can last for a few more days, and IgG can last for a few more weeks or months together. So we cannot differentiate between the acute and the post-infection. And there is a technical variability. This is the main hindrance. So most of the kits we are using, especially with the typhoid test, they are not standardized. That's where the problem comes with the typhoid test. Though it is a very good one, most of some of the papers that tell we found in our institute like that typhoid was positive like that one. So only that kit was good. So the same kit may not be available in your institute or in your area. So there is the technical variability differences in the test kit and interference from other conditions. Autoimmune disorder is the one that will act like that acts like a villain, so, or something like that. It can give a false impression of an infection is there. So that is one point we have to keep it in mind. Then there is a limited information on pathogen load. Quantitative limitations are there. It won't give a pathogen load or its replication rate, which can be important for assessing the infection severity and making treatment decisions. This point we found in a case of COVID of late, that we remember that one. And a complex interpretation. What is something like a pretest probability? When there is no epidemic and endemic of that infection is there in your season, and simply if you do, for example, dengue, sometimes if I do when there is no rains or anything like the summer season, it used to come positive. So we used to think it is a dengue, but NSN used to be negative. Whereas the IgM used to be positive, the IgM was there because some other reason. So something like a complex interpretation is there. So always you have to interpret the serology with the clinical correlation, what we call the syndrome. I mean, symptomatic collection of the thing, where your pretest probability of a clinical diagnosis is there. Then if the serology test comes positive, you can take that one. So these are all the points we have to keep it in mind. So if you keep all this in mind, even the viral test also can be a positive tool in a district headquarters. But we are not taking that one. That is the main limitation of that one. Simply we are jumping to the diagnosis. And the antibody response may not be strong enough, limited specificity. And in a newborn, we know it will be a passive transfer of the antibodies from the mother. And in immunocompromised test, it is really a great havoc to us to diagnose that infection in an immunocompromised test. With all these in background, we'll go some few cases wise. We'll discuss this some more in detail. Some of these things. So this is a 6-year-old female child, 3 days, high grade. I have not given any. It's a straightforward diagnosis because I have to discuss about the lab. Then there is a real straightforward. ENT throat congested, toxic look, no hepatosplenomegaly. So possibility is naturally viral fever, dengue fever, UTI, entry fever, malaria. These are common diagnostic differential diagnosis. Always we keep it in mind when such picture is there. So naturally, the treating pediatrician sent for the CBC, PS for MP, RMAT, blood culture, dengue panel, urine routine and culture. So see the result here. TLC is 3,200 and platelets are 1.6 lakh. Urine routine normal, blood culture awaited. Okay. So this is show there is a leukopenia is there. So it could be a dengue positive, it could be any viral infection, influenza or anything like that one. So what exactly is happening? So this is the picture we discussed in the thing. So because the time shortage, I will go there. I will move on. So the specificity, when you isolate the virus, the specificity is very high. Of course, there are some negative things are there because even you can diagnose, pick up the old DNA. That is a different story. But the thing is, the specificity is high when you isolate the pathogen, whether the blood culture or anything like that. Then genome detection, and so that's one, and antigen detection. As we move on to the right side, the specificity decreases and the opportunity to infection or to be sensitivity could be there. So that's what. So they're the direct method and these are the indirect methods. So the indirect method, one is the serology, IgM and IgG, that we have to keep it in mind. So in this case, what happened? NS1 came positive, IgM positive, IgG negative. NS1 positive, IgM negative, IgG positive. Those are two case scenarios for there. So as I told, whenever then NS1 positive is there, surely it is a case of a dengue. There is no doubt about it. And here the IgM positive, IgM negative. So already I told IgG is a late reactant, it comes later. So this is a primary dengue infection. Whereas here the NS1 is positive, no, we know it is a dengue. But when the primary or negative, how can you differentiate? Primary or secondary, how can we differentiate? IgM negative. In a case of secondary infection, IgM will disappear very fast. Within 1 day, it won't wait like 3 to 4 days, like unlike in a case of primary infection, it disappears very fast. So it does come negative, whereas the IgG will be highly positive. So this shows there is a secondary dengue. So this is the way you are going to differentiate primary versus secondary infection. So this is the same story. I think I'll move on. Then so there is a case of dengue. We know what exactly it is. There is no doubt about it. So coming to the case 2, 4-year-old child, male from rural area, fever, high grade with chills and rigors, 4 days, vomiting present, ill looking, poor appetite, hepatosplenomegaly is present. What are the possibilities? What investigation at this point of time? So same investigation because the clinical picture are there. So malaria, dengue, enteric fever, and UTI. So what exactly happened? This is the interesting thing here. Investigation CBC was done. Tears for empty, urine culture, viral test, and blood culture was done. So what exactly happened? Hemoglobin 11.8, PCV 35.4, total count 3,800. We know up to 4,000 some lab, 4,500 some lab. So anything less than 4,000 is a leukopenia is there. And platelet count are 1.6, urine routine normal, MP negative. Now there comes the point. The viral test is O is 1 in 160 positive and H is 1 in 150 positive. So can we take that one? So I will go back to the previous case. It is a history of only 4 days of duration and is already sent for the viral test. It has come negative. It has come positive. So naturally he started treating it like a typhoid fever, started on ceftriaxone and fever subsided within 48 hours. This is the second clue here to tell it may not be a viral, it may not be a typhoid infection. We know in typhoid infection, which is an intracellular organism, it takes time to disappear. The fever takes time to disappear. So in this case, it happened. So the blood culture came negative. What to do next? Is it enteric fever or not? Because the viral test has come positive, which is done within a week, that is on the 4th day, that is 1 in 160 and 1 in 60. So let us go now what exactly how to interpret the viral test. So let me clarify the disclaimer myself. As a general protocol, the blood culture is the modality of choice and serological tests ought to be avoided as far as possible. This is the disclaimer we added to that one. But as I already told, I could see a lot of medical colleges in the interior of the state doing the viral test and diagnosing, lots of practicing, general practitioners, everybody doing the viral test. So let us not discard it so easily. So because people are very, so let us have some practical things how well we can use this viral test. So it has got many limitations. So it is a serological test. Measure the agglutinating antibody against the OH antigen which are present. OH is an cellular antigen. O is a somatic antigen, we call it as. So what exactly happens? So as I already told, the antibodies always take time to appear. Maybe it's varying from 2 days to anything 1 week. Most of the bacterial infection commonly we see take about 1 week to antibodies take one week to appear. So in this case, have done on the 4th day has come positive. So what exactly it is? O antibodies which are predominantly IgM. So they are IgM, predominantly IgM, though IgG could be there. But whatever we are testing in the viral test is most of the times an IgM that usually appear on the 6th to 8th day. So remember, they start appearing only after a week. So before 1 week, if the O antigen positive, it may not be due to the recent infection. It may be due to an old infection or may cross-reactivity could have been there. So the H antibody, which are IgM and IgG. So H antibody, what we do in viral test, it contains both IgM and IgG. It starts appearing on the 10th to 12th day after onset of the illness. So remember this fact. Whereas in our case, it started it came positive on the 4th day. It means it is a not real case of a typhoid. So these points we had to keep it in mind while interpreting the viral test. So the O antigen is early to appear and disappear, whereas H antigen appears late and remains elevated for longer reactivity. So there is a cross-reactivity with other Salmonella species and enteric bacteria of the O antigen. So this point we have to keep it in mind, and is also shared by paratyphi O and H like that one. Then we'll move to this. So the limitations are here. We know it. In endemic countries like India, there exists a baseline antibody level in the population following repeated exposure to Salmonella infection. Any Salmonella infection need not be typhoid. It could be other Salmonellosis. Also can give rise to the O antigen rise in that one. So interpretation of viral titers becomes difficult unless there is a baseline value or known. In your district area, in your local area, what is the infection? For example, in Navy Mumbai, so there was a huge endemic of Salmonella typhi about a few years back. So everybody who had done the viral test used to come positive because there is a subclinical infection, everything was there. So that's the reason you should have a data of your district center, how much it is prevalent. So what could be the minimum level of the H antigen, H antibodies and O antibodies, that one. So anything above that one, probably you may take it could be an evidence of a recent infection. Otherwise, it is a very difficult. Like in this case, 1 in 160, 1 in 160, both H and O. Probably that is a normal level in that geographical area. So that's where we have to take it in mind. So due to previous antimicrobial treatment, viral be falsely negative. This is the important point I wanted to highlight. So a rising titer is an important thing. If you really wanted to have for example, if the clinical syndrome is there, you think it is a typhoid fever. There is no vaccination in the child. Really, you think you can start it. But to be on a safer side, you would take a rising titer after a week later. If there is a rising titer is there, you can be confident, okay, what I treated could be a typhoid fever. Otherwise, no. So for the next case, you be careful. It may not be typhoid. So somewhere we had to, the science has to be adjusted somewhere as the facilities are not available everywhere. So this is the one answer probably I can tell how can we use it. Somewhere we had to balance the science along with our other things. So then coming to the whatever the typhoid test. Typhoid test is based on the detection of both IgM and IgG against a 50 kDa outer membrane protein antigen of the Salmonella typhi. So it is an IgM and IgG against the 50 kDa. It is a simple rapid economic test, will be positive from 2 days after the onset of the fever. Whereas the viral will be positive 1 week later, whereas the typhoid can be positive after 2 days of later. Okay. Then it can be positive in other infections like malaria, dengue, UTI, tonsillitis, pulmonary TB. So this is the problem. So all these checks are not specific for entry. There could be a cross infection with other infections. That is important. But one important thing about typhoid is that one, the negative predictive value of the typhoid was 87.9%. So if you do a typhoid test on the third day, because it becomes positive on 2 days later, so I have seen many times they are doing on the first day, second day, and starting the treatment. No, wait for 2 days. On the third day, if you do a typhoid test, and if it comes negative, surely there is no enteric fever. So it has a very good negative predictive value of 87, almost 90%. You can take that one. If it comes negative, there is no typhoid. If it comes positive, it may or may not be typhoid. That is the thing. So this is the one way we can have an indirect evidence about the enteric fever, because somewhere we can avoid a huge abuse of antibiotics. That's what I'm trying to tell here. Nothing else in that one. So if it comes negative, don't think of enteric fever. Okay, there is a thing. So in this case, fever disappeared within 48 hours. Unlikely in enteric fever, we know in enteric fever at least it takes the deferences started appearing the 5th day onwards. because of the peculiarity of an intracellular organism. It stays in the lymphoid tissue, so it takes time, and blood culture negative, so could be a case of a viral fever. So this is one way of interpreting the entry fever in a where the facilities are not available. Now we will move on to the case 3. 5-year-old child, fever of 7 days duration, associate pain, abdomen 3 days, history of going on picnic to a forest area, febrile, rashes on the extremities including palms and soles, hepatomegaly present. So what are the possibilities? So probably it could be a case of a rickettsial fever. There is a syndromic evidence is there. For example, going picnic or a forest and there is a palm and sole petechial reaction there. It's a clinical possibility. We are not the diagnosis, a clinical, a syndromic possibility or something, or otherwise called as the nowadays, the pre-test probability is there. So CBC, blood culture, dengue serology, and Weyl Felix test was done. So TLC came 4%, still leukopenia, platelet thrombocytopenia, blood culture report awaited, dengue negative. Weyl Felix test came positive, 1 in 320, it is positive. So can we take it as a case of a rickettsia? There is a clinical evidence is there, syndrome is there. So started on doxycycline and fever subsided from third day onwards. Okay. Now how to interpret the Weyl Felix test? So what is Weyl Felix test? It is a non-specific agglutination test. Once again, it is a non-specific agglutination test. Here, you're indirectly you're diagnosing the rickettsia. That is the funny thing here. Okay. What is the thing is it uses the antigenic cross-reactivity between rickettsia and certain non-motile protease serotypes to detect the anti-rickettsial antibody. The funny thing is that the protease organism and the rickettsia share one common antigen, that is called the O antigen. Okay, so we are testing the O antigen of the protease. So that comes positive. Indirectly, we are telling it is a case of rickettsia. So why not in the protease infection? That possibility we are not keeping in mind. So they are simply jumping and telling, yes, this is a rickettsial infection. That is the problem with the Weyl Felix test. So what is the thing here? The P vulgaris OX19 positive in case of typhus group, P mirabilis OSK positive in scrub typhus type, P vulgaris positive in OX2 and OX19 in spotted fever group. So this is a different way like that one. So both rickettsial antigen protease OX, O specific polysaccharide chain of outer membrane lipopolysaccharide antigens are recognized by the anti-rickettsial antibodies in a patient serum. So they are binding the anti-rickettsial antibody. If you have got an infection with the rickettsial or with the protease, whatever the antibodies are produced, they will cross-react with this antigen and it comes positive. That is the thing. So a positive result occurs 5 to 10 days. Already I told the bacterial infection takes about 1 week after the onset of the illness, and a single negative test cannot exclude disease. Repeat 7 to 14 days after the original showing of a fourfold or greater increase will be used to confirm the diagnosis. A threshold for agglutinin that is considered normal is up to 140. Anything up to 140 considered as normal. But in few cases in India, we have found a positive titer of 1 in 320 has been observed in 54% of healthy individuals. So now you tell how good enough this Weyl Felix test to believe on that one. Okay, 62% of the individual with non-rickettsial infection indicating a low sensitivity at this threshold. So something above 1 in 320, probably you are diagnosing a rickettsial infection. And anything less than 1 in 320, it is balancing. You have to be more symptomatic syndrome, what we call a clinical syndrome. If you really clinically you are thinking of a rickettsia and Weyl Felix come positive, probably you can start on doxycycline. Otherwise, no. Completely depending on Weyl Felix is simply not possible. Scientifically not possible. Okay. So the approach to the diagnosis of rickettsial infection, a syndromic approach may not be always there, as many other infections mimic it, like dengue, viral infection, sepsis, enteric leptospirosis, and first treat specimen from blood, buffy coats, plasma tissue, swabs from the base of the ulcers. Second week, ELISA test for IgM, IgG antibodies can remain detectable for months to years. That's what I told. Even IgM also can stay, and IgG after infection. So in resource limited areas, where Felix test can be done. That is the only thing is there is another scoring system is also there. I found in one of the medical colleges very nicely using the scoring system. That's what the thing. So coming to the case 4, if the time is up, you can tell me to stop. I can stop. Rajendran or Ashwath, no issues at all. Case 4, 7 years male, fever of 5 days duration, associated night sweat, pain in the joints and arthralgia and headache. On examination, pallor present, no rashes, joints not swollen, hepatosplenomegaly is present. DDs, naturally we know, dengue, TB, EB virus infection, enteric fever. And what was the investigation? CBC hemoglobin is very low, 7 grams. TLC just normal. Platelets, there is thrombocytopenia. CF, no abnormal cells, dengue negative blood culture sent. So initially managed symptomatically, no improvement, blood culture, no growth, ultrasound abdomen, micro abscess in the spleen, sent for Brucella PCR came positive, treatment started for brucellosis. So the micro abscess in the spleen in the ultrasound is one of the diagnostic feature of brucellosis. Of course, there are other few things are there, but DD is very narrow. So one of the things when there is an history of taking the wrong means like that, then probably one of the clinical syndrome we can think of brucellosis. The diagnosis comes from by isolation of the Brucella species from tissue or body fluid. Brucella specific IgM antibodies are produced in the first week after the disease onset, reaching a maximum after 2 months. IgG antibodies are detected after the second week of infection, attaining a peak level of 6 to 8 weeks later. IgG response coincides more closely with the clinical course. So if the IgG is coming down, the patient is improving. That is one important point that we have to keep it in mind. So how to diagnose brucellosis? Once again, the syndromic approach. History of consuming raw milk is one of the things. Unwashed vegetable, there is another good history. We have to take it in mind. And brucellosis is a great imitator. It can imitate anything from tuberculosis to anything it can imitate. That we have to keep it in mind. A clinical picture of arthralgia, fever, sweating, chills, headache, malaise, which is supported by the detection of specific antibodies at significant titer. So culture, serology, and RT-PCR. Culture from blood bone marrow takes longer period to weeks, so it is only the culture, serology, and RT-PCR that will be helpful. The serology is one of the things that is very highly not specific. It is very sensitive. It is the Rose Bengal test, the serum agglutination test, and the antiglobulin or Coombs test. These are all Coombs test is an indirect evidence. It may not. So many times you have done and take it as an evidence. We know the Coombs test can be positive even in mycoplasma also. So it is not the D indicator. Of course, a clinical picture combined together probably it may help you. But the Rose Bengal slide agglutination test used to screen sera for IgG, IgM, and IgA antibodies against the brucella. The diagnosis sensitivity and specificity of Rose Bengal test compared to culture as the gold standard were almost 87.5 to 100%. So this is one important Rose Bengal test. If you are in the resource limited area, probably we can use this Rose Bengal test. So the recent studies have shown from Jaipur where I was there, it is not so high sensitivity and sensitivity, but still it was good. Around it was, I think, remember around 50 to 60%. So it was a huge study they did that one, but still it is a good one. So that is the one. So Coombs test 1 in 180, ELISA for IgM and IgG after a week, false negative possible in early infection, cross-reacted with Yersinia, Francisella, Vibrio will be there. So serology that we have to keep in mind. Maybe that was one of the reasons. Probably the Rose Bengal test was not so positive in Jaipur.
Dr. Ravi Shankara, sorry to interrupt you, sir. Can we finish with this case scenario, sir? We are nearly 45 minutes into the program. We have only 45 minutes more left. Can we finish with this case scenario and take some questions, sir?
It is over. It is over. It is last slide. The serological test had to be interpreted along the symptom syndrome and cannot be interpreted alone. Cross-reaction, late appearance, and need to repeat for rising titers or is drawback in routinely applying. Still the best in the resource-limited areas in AMR management. A general knowledge of the microbial endemicity epidemiology is required in interpretation. Thank you.
Thank you so much, sir, for that rapid revision masterclass on the appropriate use of serology in infectious disease. We can have now a couple of questions on the.
Wonderful,
may we have Dr.
Wonderful presentation, sir. As usual, Ravi Shankara, sir. Thank you, sir.
Thank you, sir.
Dr. Sri Krishna?
Yes, sir.
We'll set the ball rolling with you, sir. Right now, we are going through flu season. at least in this part of the country, we are seeing lots of H3N2 isolation. So can you please elucidate on the current criteria followed, because Nelson doesn't recognize category A, category B, category C. In practice, when the patient comes in a flu season, how do we increase the diagnostic possibility of influenza?
Yeah, actually, basically, we were following our category A where all are asymptomatic. Category B, where again we were classified into 1 and 2. And category 3 is sick cases, sir. So based
category
on that,
1, when a child comes with fever, cold, cough, sore throat, this is a very undifferentiated viral illness. What are the clinical pointers that you would want us to consider influenza as an etiological agent?
Okay, first maybe there is a epidemic, like maybe there is a epidemic cluster of cases happening. Then we have no proper other localizing feature for other infections, like maybe a proper pharyngitis or some other causes. So there is no other localization thing. So these are the way we need to consider it, sir. And the child will be like this category A will be a stable child, but we might be very careful. It might progress to a grade B or C also.
So when do we practically actually ask for an RT-PCR on the throat swab, because it is both prohibitive in its cost and what is the diagnostic yield? What would be the best time? Would all children coming with flu be offered to an antigenic diagnosis?
No, sir. Actually, we reserve it for high risk cases like our ICU cases or child on with other comorbidities. Comorbidities may be a congenital heart disease or maybe some other immunodeficiency. These are some conditions where I think we are justified in doing, and best is to do it at the earliest stage, because the better we start anti-flu or oseltamivir, better is the efficacy in our child. The later we start, the efficacy is almost very negligible. So we should reserve it for high risk cases, ICU cases, or maybe little like a immunocompromised child, sir.
Okay. So if I read you right, there is a very common practice of writing oseltamivir for all children with viral URI, saying there is an epidemic going on. 3 people, 4 people in the family are down, red eyes, runny nose, moist mucosa, red lips. This is enough to call it flu, and therefore people are very happy to write oseltamivir. Is that an appropriate use of oseltamivir? Should you do a throat swab and prove?
Yeah, but only thing, sir, here what we do in our AG hospital is actually right now we are doing a study, in the sense we in government sector they doing it free of cost, but it is only for admitted cases. So routinely OPD basis we don't do it, because sometimes they do it once a week. The result we get after a lot of after 10 days or 20 days, where we don't even follow up the report. But we don't straight away start oseltamivir. Testing is individualized, sir. Maybe ICU, maybe based on our clinical judgment, we do the testing, sir. But private is very expensive. Our RT-PCR will cost around somewhere between 2,500 to 5,000. So that cost effectiveness is also an important factor here, sir.
Okay, so we understand that for clinical efficacy, oseltamivir should be started earlier than later. We also see children with we also commonly see children who have a proven influenza infection, who are having persistent fever and chesty cough and focal respiratory findings. At what point of time would you consider a secondary bacterial infection? And if at all we need to give antibiotics for children with complicated flu, what organism should we target? Should we cover Staphylococcus aureus? Should we cover Streptococcus pneumoniae? I mean, what would your antibiotic choice be?
Yeah, sir, actually the biggest problem with the flu is basically it causes damage to our ciliary epithelium. And the flu, if you take the structure, microbiology of our this one, that neuroaminidase specifically kills our destroys your salicylic acid destruction, causing more multiplication of your virus, and it is also nidus for our bacterial infection. So the organisms which thrive here are your Streptococcus pneumoniae, Staphylococcus. So basically, and when do we consider it? Our child is not going according to a plan. basically in spite of proper treatment, the child is not improving. Then sometimes when there is sinusitis, otitis media, or other comorbid bacterial infection, also we may have to start antibiotics. Then if there is worsening of clinical condition, or if the X-ray there is change in the X-ray, maybe you have a like a staphylococcal picture, or the X-ray worsens from a viral picture goes to bacterial picture. I think there you are justified in starting antibiotics, sir. Otherwise, routinely we should never start antibiotics in a child if we are suspecting flu. We should just wait and watch and monitor the child, sir.
So what would your choice of, what would your recommendation be if you want to cover these two organisms? What antibiotic is suggested? I mean, what is your practice? What's your institute's practice?
Yeah, our institute protocol here, we start, since we start with, if we are suspecting Streptococcus pneumoniae, we start with ceftriaxone, sir. And if we are suspecting Staphylococcal aureus, basically MSSA or MRSA. So vancomycin will be your drug of choice. Otherwise, cloxacillin, clindamycin also we start, sir, based on the baby's condition.
Mm-hmm.
I
And
think
highest case, if you're getting
we have
referral
to be
from
little
outside.
careful here.
Yes, sir.
Yes, sir, Dr.
Yeah, go ahead, Krishna. Go ahead.
No, Dr. Ravi Shankara, we are happy to have your comments, sir. If it makes it more interactive and dynamic, please feel
No, I will
free to
pick up the
disagree.
antibiotic because in last 1 year in my influenza, whatever the thing in my ICU unit or like that one, the antibiotic usage is almost nil. That's the letter of appreciation given to me from the government, from our
AMS.
team. So we are AMR team. So I have not used it at all. So I use it only when there is a fever is not subsiding, it is increasing. And if I do a CRP or something like that, and if they're increasing thing, baby is worsening, requiring more oxygen thing, and the X-ray if I had done once and if you repeat it, if it is a worsening, then probably that is the indication for me to start an antibiotic. And if the patient is already immunized very well, of course, we know the government setup also, they are doing the Haemophilus influenzae vaccination, everything, and streptococcal pneumonia also done. Probably it could be still a streptococcal pneumonia. We always go with the, depending on the condition of the child, either with amoxicillin or ceftriaxone. One of the two, not vancomycin or anything like that straight away, unless until the X-ray clear-cut show there are pneumatoceles, everything is there, or a highly toxic child, then probably we don't want to take a chance. Then probably that is the period we'll think of vancomycin. Otherwise, the drug of choice always is the amoxicillin or ceftriaxone bar. But it is most of the time always I start with the amoxicillin.
And thank you for sharing your insights, sir. Dr. Srikrishna, back to you.
Yeah.
Yes, sir.
So with regards to influenza vaccine, we've always had this confusion. India has been getting two vaccines, northern hemisphere, southern hemisphere. What is your practice in Mysore? In Mangalore? Do you believe in the northern southern divide, or you give the vaccine whichever is the latest? What is your take on vaccines?
Sir, actually we give vaccine whichever is available, sir. We should not deprive the child of vaccine. But having said that, we should know actually what is this northern hemisphere strain and southern hemisphere strain. Then we India, we are in the northern hemisphere, but what WHO classifies as a South Asian country. So India itself, we follow southern hemisphere strain. Now your northern hemisphere, the WHO has a meeting 2 times a year. Once in the February for northern hemisphere, the vaccine comes after for southern hemisphere, northern hemisphere after 4 or 5 months, and for southern hemisphere during the time of September, and this vaccine comes after 4 or 5 months. So ideally for India, except for Kashmir and I think Vellore and Tamil Nadu, where the rainy season is little late and the season is little November, December. So other places and all, recommendation wise, I think southern hemisphere vaccine should be taken, sir. Other places, that 3 places, northern hemisphere, we can plan accordingly. But having said that, whenever the child comes, we should never deprive the child of vaccine, and it should be given as early as possible, sir.
One last question before we move on to Dr. Ravi Shankara, sir. A
Yes, sir.
child has had a very rough time with influenza. The child had secondary infection, was in the intensive care, required ventilation. Parents
sir.
are saying the child has recovered from influenza. We made a mistake in not vaccinating. How
Yeah.
soon can the child, after recovery from influenza, be given an influenza vaccine? Is it needed, or will H3N2 antibodies give cross protection against H1N1 and influenza B?
No, sir. Actually, we will have to vaccinate this child, preferably when the child is stabilized. Whenever the child is before discharge, I think we have to basically we have to see whether this child is primed with vaccination or not. Otherwise, we will have to definitely vaccinate this child, sir. Even in spite of giving vaccination, the immunity usually for influenza is not that much. It wanes over a period of time. So definitely, we'll have to vaccinate this child.
Okay, and in your opinion, it should be at the time of discharge from the present influenza attack?
Yes, sir. That should be the right time.
Okay, thanks for your inputs. Dr. Ravi Shankar, sir?
Yeah.
Question to you is, we are also seeing a sharp uptick in the number of children who are coming with RSV infection who are not following the typical bronchiolitis, happy wheezing child, sir. They are coming with acute respiratory illness, sometimes with secondary infection. And we are also being bombarded with the availability of passive immunization in the form of nirsevimab. So I would like your opinion on what are the current guidelines on the management of a bronchiolitis where the child is sick and needs to be hospitalized. We can hear bilateral crackles and wheeze, and the child is unwell, the child is hypoxemic. So in addition to providing breast milk, fluids, oxygen, what is the current role for salbutamol, steroids, nebulized racemic epinephrine or levotadrenaline or hypertonic saline? What are the current guidelines, sir? What is your practice?
Tricky question. You want a scientific evidence or a practical evidence? That is the thing.
No, practical,
Yeah,
sir. Please
as we
let us know what
yeah,
you do.
as we know, the clear cut the book tells no bronchodilators, no steroids, and even the hyper saline is almost questionable like that one. But still, people are depending upon that one. So what I am doing in my thing. So usually avoid if there is no wheezing, avoid the bronchodilators. Okay, hypersaline solution. I try to use it because we know it is the bronchioles that is the affected. So there's some amount of and humidification may help. So the evidence, the evidence we get is B or C, not the A. So, but still it is useful maybe in few cases. So thinking that this case will be useful, I'm using that humidification and giving oxygen is the main important thing. And if the patient is not improving with that one, then we are going to with the HHFNC. That is one almost giving they improve like anything. The main thing is.
Your voice is breaking quite a bit, sir.
Hello?
Your voice is breaking,
Am I
sir.
audible? Yeah. It showed that
intermittent.
Yeah, now?
Yes, sir. Now better, sir.
Yeah. So with the HSFNC, how the patient improves is really fantastic. Really a distressful child relaxes like anything. Something you have given a very good, wonderful thing, and the patient improves fast. That is the HSFNC that is we are using depending upon the ABG findings and the hypoxic level of the child, and we are using that one. Otherwise, it is a symptomatic treatment with humidification and with oxygen. That is the thing we are giving, and we are giving IV fluids also because a good amount of hydrating the child is a good sign. Is one of the good sign that has been advocated. This is the way we are managing the case.
Okay, sir. I wanted your opinion on the recent recommendations for giving nirsevimab during the RSV season, even for healthy babies. Initially, they were saying palivizumab for at-risk babies. Now there's increasing pharma pressure, even in ID conferences. There's a lot of talk about the new molecule. Is nirsevimab needed at all? Do you think it's a hype, hope? Do you think it's a game changer? What do you think, sir?
I have not used it so far. Point number one. Okay. So In fact, in our upcoming NCPD also, that is probably one of the top talk will be there on that one. Okay, so there is a point number 2. Point number 3, as we know the mechanism of action of the nirsevimab, where it binds to the virus and makes the virus not to bind to the membranes of the cell. So, in fact, avoiding the infection in the child. So, the mechanism of action is really good. No doubt about it that we have seen it in a case in COVID, how it is work like that one. But the hindrance is the cost. It is almost 50 to 60,000 rupees, depending upon the age of the child and weight of the child. So that who can afford that one? When they are not getting a blood culture in a district headquarters to tell that use nirsevimab, I mean, whether the patient can afford, those who can afford probably can do it, because the WHO has also recommended that one. So there is no harm in recommending that one, and theoretically it has to work well. But I have not used it so far.
Thanks, sir. Thanks, sir, for that honesty. Dr. Sri Krishna, question to you, sir, again.
Can I come here, sir? 1 second, sir. Like, what is your experience with the nirsevimab, sir? Like, have you used it, sir, in Coimbatore?
Me? No.
Yes.
I don't do active neonatal practice. So as I understand, the recommendation guidelines say all healthy infants less than 8 months should be offered nirsevimab, and it is advantageous over palivizumab in the sense it can be.
Yeah, that is actually AAP guidelines, sir. AAP guidelines.
Correct. So that's what I'm saying. I'm keen on knowing what is the IAP's take on it. That is why the question is put to you.
Okay.
So whether we are going to have a more tailored approach, it's available now. People are paying 20,000.
It is available in Bangalore. It is available.
No, actually, I have
some of the centers they are using it.
I have used in one of my patient 1 week back, sir.
Okay.
So
it is available. So whether we like it or not, we'll have to take these questions from anxious parents, because they will be able to see that it's available, but our doctor is not recommended. That's why the question was. Dr. Krishna, question to you was, and now we have the upper respiratory panels, the biofire panels for common respiratory pathogens. How often in your practice do you actually use a PCR panel? Do you find it useful?
Hello?
Yes.
Mostly in our ICU practice, we just use it, sir. Actually, PICU
No, I'm
use
talking about in OP practice. When a child comes with a respiratory tract illness, you want to know whether it is influenza, parainfluenza, mycoplasma. What is the utility of a PCR, upper respiratory tract, nasopharyngeal swab PCR? How often do we use it?
Maybe in the hospital setting, not much, sir, but private side, basically for antibiotic stewardship. Suppose if I feel strongly we are suspecting influenza, then definitely do it in a private practice. Otherwise, hospital wise, not much routinely. Respiratory panel we don't do, sir. Patients are not that much affordable to do that, sir.
Okay. So while on the subject of upper,
and only thing, another problem is sometimes difficult to differentiate between the commensal and the organism also, and the cost also, and sensitivity. That is the main issue, sir. That is the problem we face here, sir.
Point taken. While we are on the subject of upper respiratory tract infections, we continue to get it wrong very often when it comes to writing antibiotics for viral respiratory diseases versus bacterial. We keep telling about McKessie criteria, modified Centaur criteria. In your opinion, as a seasoned campaigner and pediatrician with attached to a medical college, what are the 3 or 4 important physical findings that can help a pediatrician to confidently write a course of antibiotics for a sore throat? Forget the McKessie criteria center. What do you think, in your opinion, has always helped you to clinch a diagnosis of bacterial sore throat?
Okay. One is the clinical presentation history. Then on examination, throat, if I have a good purulent discharge, if I have, then if there is ear discharge, if there is sign suggestive of otitis media, then that I think that are some of the indications where we definitely should. Otherwise, more and some petechia can be seen. Otherwise, mostly it is 90% of the time it is viral, where we definitely don't start antibiotics.
Okay. And what is your take on the recommendations, RTHM guidelines, IAP guidelines continue to recommend 50 mg per kg of amoxicillin in 2 or 3 divided doses. But whether we like it or not, in actual practice, repeatedly people are using co-amoxiclav. So what is your take? When should we give co-amoxiclav upfront, or are you happy to give amoxicillin? The second sub-question on that is, we are also having this pharma people promoting something called amoxiclav ES, extended spectrum, a higher concentration of amoxiclav. What's your take on that? When would you want a pediatrician to consider that molecule over the humble co-amoxiclav?
Okay. If the child has already put on amoxicillin or child has not improved, maybe there we can use amoxiclav, sir, or upfront some otitis media, or some condition. That is where I think we can use upfront amoxiclav.
And what about amoxiclav ES? Is there an indication? Do we see so many resistance? Do we see so much of resistance to amoxicillin that we should be using amoxicillin ES for
No,
acute
sir.
otitis
Actually,
media?
we're not using that much, sir. Yes, here.
Dr. Ravi Shankara, your take on amoxiclav and amoxiclav ES, sir? Do you have any difference of opinion or insights?
Yeah, well, if you're reducing the clavulanic acid dosage, first of all, I always go with the amoxicillin. And if somebody is telling you use lesser clavulanic acid, happily I will take that one. So if they have found scientifically that a little amount of clavulanic acid is sufficient to protect the amoxicillin, that is enough. Because whatever the side effects of clavulanic acid, like the gastritis, all those things, it will be reduced, and acceptability of the child will be good. So why not that one? So I don't have any objection for that. So because first of all, I always hate to use clavulanic acid. I always go with amoxicillin. So if somebody is telling less of clavulanic acid, accept it. That's all my feeling.
Right, sir. Thank you so much. And you talked quite a bit about the use of typhoid Vidal and the relative non-utility. That is one of the biggest bugbear for the practicing pediatricians, because in a teaching institute in Mangalore, where Coimbatore, where I practice, we have the luxury of asking for blood culture. People generally will come and see you after 2 days, 3 days of high-grade fever. But practice, what happens is, because of parental pressure or uncertainty about diagnosis, invariably some antibiotic gets written. So I want you to specifically tell us whether alternate cultures, we're not talking about bone marrow cultures, whether stool culture can pick up salmonella, because stool culture is far more widely available than blood culture, at least even in Mofussil cities. And we know that Salmonella typhi can be excreted in the stools. What is your experience with stool culture to pick up typhoids?
After a week, after 1 week of fever, the stool culture will be more positive compared to the first week. The first week is the blood culture that is the most important. After 1 week, still we can go with the stool culture if it is done. Otherwise, always the best one is the bone marrow culture. No issues at all.
Okay.
Because we know it is
So
activated
again,
in the stool, and we can do it. And after the first week, the blood culture positivity will be less. Yeah.
And in practice, when we do a CBC on day 3, day 4, are there any specific pointers? People like Dr. Paniraman have always given a lot of importance to the eosinophil count. Eosinopenia, they believe, is a very, very important point. Do you find that information useful, sir?
See, in the whatever the Dr. Amdekar's book, it is clear-cut mentioned. Eosinophil 0 goes with the enteric fever. So the Paliniraman accept that one, but we have not seen that one at all. Probably in the whatever the microbe land, in the microbe world, they have got their own rules and regulations.
Correct.
So they always change that one. That's the reason they are surviving. They were there before we born. They are billions of years. They are surviving, and still they are going to survive because they have got their own rule books. So I don't believe in that one. So probably it was there about 20 years back. Now it is not there. We are not got that.
And this is holiday season. GST has come down on paneer paratha and butter masala. So snacks, unhealthy food has also become cheaper. So we generally would snack during Diwali time, Navratri time. So I want to know your experience with non-typhoid salmonellosis. Do you see it after eating bel puri, pani puri, chaat items. Is that a common problem? Because we have had fatalities in Tamil Nadu where people have had shawarma and cheap people have succumbed. One of them was a medical graduate student also in a place called Namakkal. So I want to know your experience regarding non-typhoidal salmonella.
It is there, sir. Surely it is there. The food poisoning, whatever they call it, the salmonella is very common and depends upon where they had the panipuri, like that one. So surely it is there, no doubt about it. Whether the hepatitis C or the salmonella is very common, and we had to be aware of that fact. So during the rainy season, in fact, the corporation here take the precaution and tell them most of the time the roadside things they avoid in some of the areas. It is there, sir, no doubt about it. Had to be careful about that.
Dr. Sri Krishna,
Yes, sir.
with respect to dengue, we've been talking about dengue vaccine and that Takeda vaccine, and people continue to tell us there are phase 3 trials are on way, phase 4 trials are on way. Anytime the drug controller can approve it. It has already proven to be a useful molecule in the Far East, like Singapore, Philippines, Indonesia. Do you see Takeda vaccine coming in the foreseeable future into the Indian market? What is the current status of the dengue vaccines in India? Can you please enlighten?
Ashwat,
Yeah.
Ashwat.
Yes, sir.
Sri Krishna does not know answer for that one. The best answer will be available if I request all of you to attend the NCPD in Bangalore, then you'll get the answer. Sri Krishna surely does not know the answer.
100% true, sir.
He knows, but I don't want him to tell all of you.
Okay, I think the rate at which we are going, we will have no registrations if all the topics are covered here.
No, of course,
Point
yeah,
taken,
we
sir.
know
Okay.
it is not still that phase 3 trials are going on. So in India at present, it is not done, not available. Probably we are expecting somewhere in 2026. To know better, please attend the NCPAD at Bangalore.
Ravi Shankara is very clever.
Watch it on the silver screen. Anything up to latest updates, you need to be in present. Right, sir. Very nice marketing. Right. Can we have your insights about mycoplasma pneumonia? Because last year we saw mycoplasma in numerous avatars. We had hemorrhagic effusions, we had respiratory failures, and we were also agonized over the fact that none of them actually responded to macrolides. So your thoughts, sir. What is your experience in Bangalore? This walking pneumonia, adolescent child coming with more symptoms, less signs. I think that is no longer, like you correctly said, mycoplasma has also moved on. It has also changed its colors and coats. So we are seeing a different and very malignant version of mycoplasma in the last 1.5 years. Your thoughts on it, sir?
Yeah, rightly told. Mycoplasma now almost have become like a brucellosis, like a brucellosis is a great what I told actor.
Imitator.
So imitator. So same thing like that. Mycoplasma has become nowadays. So when you are not getting anything positive and patient is not responding to the usual amoxicillin like that one, probably mycoplasma has to be kept in mind. Thankfully, mycoplasma has not come this year, not so much. Whereas last year, as you rightly told, almost every alternate case used to be mycoplasma different, and thanks to the RT-PCR, we were able to find it early and we were able to treat it correctly. And unlike in Tamil Nadu, where Bala has produced the resistant to azithromycin, thankfully in Bangalore, most of our cases were sensitive to azithromycin.
Okay. Because our experience was that we had to give doxycycline for the really unwell children. Our failure rates were very, very high.
Yeah.
Okay. Concerning, we'll move on to some more obtuse infections, sir. I wanted to know what your experience with etiological profile of infectious disease in acute febrile encephalopathy. I understand we will have pockets where JE is common. We will have now this primary amoebic meningoencephalitis scare that is coming in Kerala. Then suddenly you will have Nipah outbreak. It is there in the news coming and going. So we will definitely have some regional variations in India when it comes to etiology of acute encephalitis syndrome. So for the practicing pediatrician, when a child has come with a sudden onset high-grade fever, altered level of consciousness, child has thrown a seizure, child is having obtundation, he is able to protect his airways. In the consideration of the pediatrician, he doesn't think it is sick enough to shift, but at the same time, he doesn't want to take a risk of not giving ceftriaxone, acyclovir. He is not sure whether it is rickettsia or scrub encephalopathy or dengue encephalopathy or enteric. So is it justified to give a course of artesunate, a course of doxycycline, also ceftriaxone, also acyclovir? I know it sounds horrible, but practical considerations, all these are accepted. What is your take, sir?
Yeah, no, not only this, Ashwat. Previously, if I remember, how we missed the diagnosis so many times during our student days like that one, because there is no investigation. Most of the time, the fever is not responding. Right away, go and put on TBM. Now we know what were those cases. It may not be TBM. It could be autoimmune disorders like what we are getting. So it was there. Probably we didn't identify that one. Same thing like that one. So here also now, always the geographical indication is very, very important thing. For example, interesting thing I will tell you, in Bangalore, JE is not there. Okay. So we are surrounded by the JE infected endemic districts like Kolar one side, Mandya on the other side, Tumkur on the other side. These are all just hardly 10 or 15 kilometers from my home. The Bangalore city as such does not have the JE at all. Whatever the JE cases they are seeing in government colleges are all referred from the Mandya or something nearby districts like that one. The reason that one, the vector is not there in Bangalore. So we have got the everything. So always we had to go suddenly thinking of a JE if it's not there in our area. Coimbatore, we know the JE is a common thing. It is there. So always think of the geographical area or the historical thing where they have gone. The rickettsia we know staying in a resorts near in Bangalore where a lot of shrubs are there. They are exposed to the rickettsia or leptospirosis in a slum area in a monsoon time. The children played in the rainwater barefooted because the rats can urinate there, the urine contaminated thing. So all this, the history is a very, very important thing. The old notion that one, either it is a JE or TBM or pneumococcal, no, that is gone. Rickettsial also. In fact, about 2 weeks back, we had influenza encephalitis also. So we had to keep all these things in mind. Influenza, adenovirus, encephalitis, rickettsial meningoencephalitis, leptospirosis, everything we had to keep it in mind. The olden days of start with this one, no, we had to be more geographically and endemic and epidemiologically to be more oriented and start the treatment like that.
Can someone please mute? I think somebody's left his phone unmuted. Yeah,
And
thank you.
Ashwat sir, here I think our multiplex PCR will also have a very good role, sir.
Correct. If we do a CS of the question, yeah. So my question was, what antibiotics would be expected of a general practitioner or a practitioner in pediatrics?
You starting
in the
in
practice in the
doxycycline.
peripheral setup. Yeah.
Yeah. Doxycycline starting in is really good idea. If you think there is an endemicity or a lot of cases of rickettsia has seen, adding doxycycline is really a good idea, no doubt about it. So you are saving so many life also in that. It is a very good idea. We are starting that one. Even in Indira Gandhi, I heard that one, Dr. Basura telling that they are starting doxycycline depending on which area that one. So it has become almost, though there is no protocol like that one. So if individually they are starting the doxycycline as an idea, as an added thing.
Okay, sir. Thank you. Thank you so much. Now, considering the menace of stray dogs and the Supreme Court also cracking down, do you foresee a point where we should be giving ARV also as part of the national immunization schedule, sir? Because considering the fatality and definitely after COVID, whether I don't know about fertility rate of India, dog fertility has definitely gone through the roof. Every state has got more dogs than people now. And we have the Blue Cross, which is championing their cause, but nobody is able to sterilize the dogs or have any control. Considering the magnitude of the stray dog menace and the fatality and the high morbidity associated with rabies, do you think high-risk people living in slums or certain geographic areas will be offered ARV? Do you think that should be the standard of care?
Little difficult thing, not only in the slums, even if I go jogging in the early morning, I am also prone for to get a dog bite thing. So it is a common, once you enter into the street, anybody whoever maybe is not, will be exposed to that one. There is no doubt about it. But the interesting thing, which I got from Anurag Agarwal, that is from Delhi, he has done a wonderful lot of job. One of the important thing, the people who died even after taking the anti-rabies vaccine, that one, not properly washing the wound. That was one of the main reasons they have found that one. A wound washing is a very, very important for about 10 to 15 minutes. A flow water is a very, very important that we had not done it, that we had to advocate it. But of course, the anti-rabies vaccine giving universally is a best thing. But one thing is the reason is, see, it is not a long lasting. Unlike the DPT or like that one where 10 years, 20 years longevity thing. So it lasts only for 3 months, isn't it? After 3 months, you are supposed to give another 2 vaccinations if you get a dog bite. So making it is a nationwide, maybe a resource crunching. Otherwise, a good education about immediately of the dog bite, what you are supposed to do, probably that will be better. If the same virus with the same vaccine was giving a long lasting, probably would have advocated, but it is not so useful. Even after a good vaccination, after 1 year also, you had to supposed to take 3 vaccination, that there is.
Sir, can I come in, sir?
Yeah.
Yes, please.
Yeah. Sir, one point here is if we provide pre-exposure prophylaxis, one most important thing is we can save on our immunoglobulins, because already
that is the only thing.
Yeah, because already they have taken, and then you need to just give 2 vaccines. There are no question of giving immunoglobulin. That is the one thing advantages we have. One more thing, sir, compared with the other.
Okay. So we have come to the last 5 minutes. Thanks. It's been an absolutely wonderful journey with both the esteemed panelists, Dr. Ravi Shankar and Dr. Sri Krishna. We thank you so much on behalf of IAP TNSC for sparing time on Sunday and staying away from the India-Pakistan cricket match and taking our questions and sharing your valuable insights. We have a couple of queries in the chat box, if you will be kind enough to answer them. There has been a query on when to start doxycycline on day 1 of fever, and then somebody wants to know whether it will be a good practice to give antibiotics for after ulcers, and whether the child refers from a bacterial infection should be reoffered vaccination. These are some of the questions on the chat box. If you can share those answers, we'll be done. Dr. Krishna, would you want to answer those questions in the chat box?
After ulcers, see, once upon a time, we used to give, this one, multivitamins and give that one. No, we know the abscess also could be a part and parcel of the acute inflammatory syndrome. Okay, we have got some of the diseases that we have found where just a paracetamol may be helpful, that one. So we have to be very careful and look into the abscess ulcers where there is a pus-like thing or something is there. Anything. So we had to case by case we had to decide about it, whether it is a infective or non-infective or something like autoimmune or auto-inflammatory. All those things we had to keep in mind. So I don't agree with that one. And when to start doxycycline, sir, from day 1 of fever. So if you are sure that it is really a case of rickettsial, probably you can start on doxycycline on day 1. Otherwise, no. How can we tell it is on the day 1 itself? It is very typical. It is just a fever. No. If the other symptoms takes time to develop, at least another 48 hours for the other symptoms to develop. So till then we had to wait. I don't agree with that one. Then what is the another question?
Vaccinations, whether the vaccines have to be repeated for MMR and varicella after bacterial infection because they believe that the immunity will wane off.
No, that is not advocated by the IAP so far. So if they have taken a very good MMR 3 doses, now it has made it 3 doses, you remember. So there is no need for that one. Only MR taken, probably had to take MMR because mumps is not available single-handed. So that's the reason we had to take MMR. Otherwise, no. And
but typhoid vaccine we'll have to take. Typhoid vaccine we'll have to take, sir, after typhoid vaccine.
No, the question is after bacterial infection. After typhoid vaccine is warranted. Yeah,
after
the question was
vaccination
very
is done,
non-specific.
No, that's we cannot know. Typhoid vaccine, of course, there is now a lot of things they are advocating for the second dose. So let us leave it to the central IAP, vaccination committee to decide about that one. If you have taken typhoid vaccine correctly, no issues at all. Of course, they have done cancer treatment, have taken, then probably loss of immunity, you may have to do it. Otherwise, in a normal competent child, no need for that one. Anything else?
Perfect. No, sir. I think most questions we have answered.
Yeah, it is a trivalent and quadrivalent. Now we know it is a trivalent because Yamagata is since 2020.
Yamagata has been taken out.
Taken off. So in 2020, they have seen it is not there in the environment.
So quadrivalent flu has become trivalent again.
Trivalent now.
Right.
Yeah.
Right. Thank you once again to both my.
Sir, that is only in this one, no, sir. Our thing is, I think, still quadrivalent only. Our next strain. Next year, they are planning to make it trivalent, sir, because this strain is not circulating since 2020. The new one
now
is
we
still
have to. What Dr. Srikrishna says is practical, but now there are a couple of pharma companies who have come up with the trivalent and believe that by giving it is a basic bit like trivalent OPV to bivalent. When OPV2 wild poliovirus is not there, there's no point in giving a virus which is going to compete for space and is clinically irrelevant. So like we made the switch from trivalent to bivalent, we also believe that quadrivalent OPV, that fourth is probably not going to give any immunological benefit. So trivalent is also available now in the market. It'll be to the practitioner's choice. We will leave it to them to decide what they want to do. So thank you once again on behalf of IAP TNC and the 4P series. I also would invite comments and closing comments from Professor Singarvelu sir, Professor Srinivasan, Dr. K. Rajendran, President of IAP, and Dr. Tirmurugan, our Academic Affairs Coordinator. We'll have their brief comments and we can say good night.
Can I make a statement?
Sure, sir, absolutely.
If I remember correctly, Dr. Kashi has recently mentioned one of the platforms on rabies that immunization, universal immunization should be a national program, if I am correct. Yeah, you can clarify on that because I heard him mentioning that. And I have been, whenever I land, go to the streets, seeing the dogs roaming around, I also feel it's very essential because you never know. Even house dogs, sometimes create problem.
Sure, sir. Sure.
Yes, sir. And one more reason to attend Bangalore Pedicon, sir. Kashi sir is giving oration.
Sure. Dr. Singarvelu sir, Dr. K. Rajendran, Dr. Tirmurugan.
Yeah, thank you very much, Dr. Ashwath. I think we really enjoyed another very fruitful session for our practitioners. And we thank both Dr. Dr. Ravi Shankara and Dr. Sri Krishna for enlightening us. And special thanks to Dr. Dr. Ashwath for conducting the session with the usual fervor. I think we are now back to our original format, which is what we wanted, and I'm very happy that we could manage to do it. And we had some really wonderful discussions and interaction. Thank you very much to both of you. Thank you, sir.
Dr. Singarvelu, Dr. Rajendran.
No, I think they are just they're on another meeting. Dr. Rajendra and Dr. Singarvelu is out of reach for that. So we'll go.
So if there are no further comments, can we close the session?
Yeah, we can.